Good evening, everyone. Let's wait for a few minutes so everyone can join the webinar.
I think we could get started. We have about 47 people in the room now.
Okay, so let's start. Good evening, everyone. Welcome to the webinar on dental analgesia and anesthesia with Dr. Soheil Khojasteh. My name is Kiran Patel, and I'm an advisor with TMFD Financial. I'm helping dentists to achieve their financial goal. I would like to begin by thanking the TMFD Dental Academy for the opportunity to speak for a couple of minutes. Tonight, we have Carla and Dr. Soheil Khojasteh with us. Before we start, I pass it to Carla to go through some of the housekeeping stuff. Carla, pass to you.
Thank you, Karen. Good evening, everyone. Thank you, everyone, for being here this evening. I'm very excited to announce that we are celebrating our 1-year anniversary with the TMFD Academy. So we've had a fantastic year of great speakers, amazing topics, and we're actually in the midst of working on our program for the coming season for 2023. So just keep your eyes out for your emails, and you can definitely check out our lineup in the coming weeks. So as Kieran mentioned, my name is Carla. I do work here as TMFD Financial as well. And before we begin, I just wanted to take a couple of moments to just cover some housekeeping items. If you've been on our webinar before, you probably know a lot of these little different tools, but just to refresh everyone's memory, we're going to just go through a few of the items here. So we'll be on tonight's webinar until approximately 8:30. If you look at the bottom of your screen, there are a number of different options, different sort of tabs at the bottom of your screen. If you have any questions regarding the presentation, please enter those questions in the Q&A box. If you have any questions related to technology or questions for myself or any of the other panelists or hosts on the screen this evening, you can feel free to enter those comments in the chat box. We will have some poll questions that will come up at the end of the webinar that will pertain to the topic at hand. And we just ask that you take a moment to go through and answer those questions. It just ensures that we have a way to make sure that you're sort of paying attention throughout the webinar. And this is all for CE credits, of course. We will be giving a copy of our book, free copy to everyone who attended the webinar this evening. The book is The Financially Independent Dentist. So for any of those who have not attended our webinars in the past, we will certainly make sure to get out a copy to you. Of course, if you've been on our previous webinars, you likely already have a copy. If you want additional copies for any reason, please let us know. We'd be happy to send you some additional copies. The last note that I wanted to mention is that the CE credits will be available within approximately 2 weeks of this evening's webinar. So we will be sure to email them out to everyone no later than September 30th. And of course, we will invite you to join our mailing list so that you can stay in the loop and get our updates about our academy. I'll place the link in the chat box. As well, we do have our upcoming webinar on October 25th. So we also invite you and encourage you to register for the upcoming webinar. So before we begin our evening's presentation, I just wanted to take a moment to introduce Roy. He is our sponsor for this evening's webinar. And Roy is just going to say a few words to everyone. So over to you, Roy.
Thank you, Carla. Hello, everybody. Hope everyone is well and ready to get started with this great webinar with the amazing speaker, Dr. Soheil Khojasteh. I know you're here to listen to him and not me, so I'm not going to take so much time, more than 5 minutes of your time. It's truly an honor to be here. I just want to thank TMFD for giving me this opportunity to be here today. My name is Roy, as Carla mentioned. I'm a managing partner at Haas Development, Inc. We are a boutique real estate construction company specializing in commercial and residential projects all over the GTA. We have been in the construction business for over a decade now, and we started out with just building luxury custom homes in the beginning, and eventually got into construction projects as well, and building medical and dental clinics, including Dr. Soheil's brand new office, Toronto Sleep Dentistry, which some of you might already know about it, but I'm gonna share some photos of his beautiful newly built dental office with you on my screen. Let me just share my screen here with you guys. Okay. As you can see in this photo, we purchased the property for Dr. Soheil, and property acquisition, as you might already know, it's one of the services that we provide. We help you purchase the property in an area of your choice, obviously, within your budget. If you're looking to start up a practice, this is what we did for Dr. Soheil, and we managed to get a really good deal on this 80-year-old property on a very good street on Bloor Street West, around High Park. As you can see, it's a very rundown property. It was an over 80-year-old property, but because we had the experience, we could see the potential, and we came up with this design, as you can see this on this rendering. Based on Dr. Soheil's taste, we came up with this design, and he gave us the go-ahead. So we went ahead and we got the permits, and we managed to finish to this beautiful dental office, as you can see in your screen right now. So property acquisition is one of the services that we provide. And let me just, this is a walkthrough, a short video of a walkthrough of his newly built office. Another service that we provide, obviously, is the dental and medical clinics construction. We can take care of your practice construction from A to Z, while you get to be involved in the whole process as much as you would like. I know some people really like to be involved, while some people just want to be involved in the design process, which is totally fine. As you can see, that 80-year-old property came to life after the construction. Another service we provide is commercial and residential renovations. If you already have your own practice, if you want to remodel your practice, sorry, I think there's a lag on my screen. Sorry about that. We can help you with the remodeling your own existing dental office. We can do any projects as small as updating your bathrooms, study rooms, cabinets, kitchen, whatever. We can help you with that. If you want to extend, if you want to do an addition on your property, if you want to add extra ops, we can help you with that. Basically anything related to construction we can do for you and handle it for you from A to Z. And also, as I mentioned earlier, we started in this business with building luxury custom home, and that is also something that we already provide, and we still provide. If you want to build your dream house, if you want to invest in real estate, if you want to buy, build, and sell, we can help you with that. This is a video of recently, actually, it's been a couple of years now, that we built this project for a client. And we take pride in the quality work we provide, and while we stay on the budget and schedule. Those are the services that we provide. And if you guys have any questions or you want to get a free consultation session with us, you can call me directly on my cell number at 416-953-8484, or email me at info@hossd.ca. That's info@hossd.ca. Thank you guys. It was really great being here today, and I hope you guys enjoy the rest of the webinar and have a great night. Thanks, Carla.
Thank you, Roy.
Thanks, Roy. As Carla mentioned, that I am very happy to share the news that Academy has celebrated its first year and excited to welcoming you back in our second season. TMFD is strongly dedicated to offering quality education to dentists at no cost or obligation. And the incorporation of a virtual platform has allowed us to arrange a series of relevant topics on clinical dentistry, as well as dental specific financial topics. These webinars are open for all dentists, will be conveniently scheduled at 7 p.m. on weekday evenings, and will last for 19 to 120 minutes, depends on the subject matter. Our mission is to provide a high degree of holistic value-added information for dentists in all areas that impact their practice. Tonight, we have our welcome guest, Dr. Soheil Khojasteh with us. Dr. Soheil Khojasteh is a specialist in dental anesthesia and has a diploma from American Dental Board of Anesthesia. He is a clinical instructor at the University of Toronto Faculty of Dentistry in the Department of Anesthesia, and he has presented to his colleagues in anesthesia and dentistry at numerous conferences. Soheil currently practices and procedural team anesthesia model in which he provides comprehensive dental treatment to his patient under general anesthesia and deep sedation. I will now turn it to Dr. Soheil Khojasteh for this evening's presentation. Over to you.
Thank you very much. Thank you, Kiran. Thank you, Carla. Thank you, Roy. Thanks, TMFT, for the opportunity. And thanks to all of you for spending your Monday evening with me. Hope you all had a great day. So I'm just gonna, without further ado, I'm gonna start sharing my screen, and so we can get going with the presentation. Can everyone see my screen, Kiran? You can see my screen?
Sure.
There?
Yeah, we can.
Perfect. Okay. So as Kiran mentioned, my name is Soheil Khojasteh. I'm a dentist anesthesiologist, and it's my pleasure to be here this evening to talk to you guys about the spectrum of sedation and anesthesia and its indications in dentistry. And as you all pretty much know, I think all dentists in Ontario know now that sedation CE is a pretty hot CE topic these days, since the RCDSO wants anyone who does even moderate sedation to have at least oral moderate sedation, even at least 6 anesthesia related CE credits each year, right? You guys are probably aware of that. So just gonna, excuse me, I didn't know that Kiran's gonna give such that nice introduction. So I just have a little bit about myself. I obtained my Bachelor of Health Sciences from McMaster University, and then I got my DDS at the University of Toronto, followed by my specialty training in anesthesia, also from the University of Toronto. I'm a diplomat of the American Dental Board of Anesthesia. I'm the current president of the Ontario Dental Society of Anesthesia, and I'm an executive member at the Canadian Academy of Dental Anesthesia. I am a clinical instructor at U of T in the Department of Anesthesia, and I also engage in private practice. So I've been working in Kitchener for the past 5 years, and as Roy mentioned, I recently opened my own office called Toronto Sleep Dentistry. It is in the High Park area on Bloor Street near Bloor and Parkside. And essentially, I provide dental treatment to patients of all ages under all modalities of sedation. So through this talk, you'll see a lot of the patients that I see, a lot of pediatrics, anxious adults, people with gag reflexes, or people who local anesthesia is not effective for. But we're going to get through that. And this is my family. This is what it's all about for me. So that's my wife and my little guy, Keon. He's 3.5 years old now. My wife's keeping him occupied. I do apologize. He is quite mischievous. You might hear him at points throughout this talk. And some of your kids, you might be lucky they go to sleep around this time. This guy is up till like 8:39 minimum. Anyway, so I do apologize in advance. You can probably even tell from his face here, he's quite mischievous. And my wife Monica is actually, as of yesterday, 38 weeks pregnant. So we should be having our other son join us anytime. So wish me luck. I have another kid coming and a new practice, so you can probably guess how much sleep and rest I'm getting these days. So this is just a little overview of the presentation for tonight. We'll start by talking a little bit about the history, definitions, and the continuum of sedation and GA. We'll talk about anesthesia and dentistry a little bit, how we can achieve anesthesia, very briefly about emergencies, and hopefully time permits for us to talk about some of the RCDSO standards as they relate to anesthesia. So history. So you guys probably all familiar with the opium poppy, and it's not used much for sedation today per se, but it may have been used for analgesia in the past because it does have some analgesic effects, which we know, for example, opioids, morphine, fentanyl, those medications do possess analgesic effects. And then 400 BC, so many years after that, but still long time ago, what they employed in medicine at the time was carotid compression. So I guess the doctors at the time found out that if you deprive the brain of oxygen briefly and temporarily, you can render the patient unconscious. And actually the Assyrians and the Egyptians used this method to perform circumcisions and cataract surgeries. And then many years after that, Greeks were boiling wine in mandrakes, and there's some hallucinogenic tropane alkaloids in those substances that would allow the doctor at the time, or barber, since it was the barber who would be doing a lot of these surgeries, to perform the procedure as painless as possible, or as to get the patient in as euphoric a state as possible. And there were many others. And that brought us to modern anesthesia. And this is probably something that we as dentists are probably familiar and hopefully proud of. So Dr. Horswell's, he took out his own tooth under nitrous and then took out a patient's tooth under nitrous. That was at Massachusetts General Hospital. But it was a partial anesthetic, and people were calling it a humbug because they said, well, your patient wasn't asleep and they still felt the pain and discomfort a little bit. And that makes sense to us. I mean, right? Even if you give a patient 70% nitrous for 3 minutes and you try to take a tooth out, they're probably not going to be very happy. I'm sure you can have some patients that will go into a state of deep sedation, general anesthesia with nitrous oxide, but that is not very likely. We know the minimum alveolar concentration of nitrous is 104, if you recall, meaning that the likelihood of rendering a patient completely unconscious, even at the 70% that we can administer, is not very high. And then in 1846, that's when Dr. William T.G. Morton made history by being the first in the world to publicly and successfully demonstrate the use of ether anesthesia for surgery. And this is the ether dome. Some of you may have visited it. It is very interesting to see. I personally have too. If you're ever, if you get a chance to visit it, it is awesome. And again, it's a sense of pride for us dentists because Dr. Morton was a dentist. And World Anesthesia Day is coming up, Ether Day, October 16th. And the significance of that is, what we just mentioned. Using ether, this doctor was able to perform a neck tumor dissection painlessly. And then from there on, we went on to, having IV anesthetics like lidocaine, ketamine, propofol, vapor anesthetics, most recently being sevoflurane in 1994. And if you read up on these topics, you probably know about some of the noble gases, right? Like xenon being employed for sedation and anesthesia as well. So this is a diagram that basically depicts the different levels of sedation. So you can have even, non-pharmacological iatro sedation if you have good chairside, bedside manner. And then what's important is this line here. So minimal and moderate conscious sedation, the patient is conscious, and with deep sedation and GA, the patient is unconscious. Now, this chart is from Dr. Malamit's textbook from 2003. And although, Dr. Malamit is a highly respected individual, I don't agree with this chart per se, because it's kind of equating the route of administration to the depth of anesthesia, which we certainly know is not true. You can have IV anesthesia for GA or a mild sedation. You can have a patient completely unconscious if you give them enough of an oral medication, right? So let's briefly go on and talk about the different definitions of sedation and anesthesia and terms that relate to these topics. So sedation, as we know, mild suppression of arousal and behaviors, and a sedative basically decreases activity and it'll calm the patient. While a hypnotic, those are drugs that produce drowsiness and facilitate the onset and maintenance of sleep. And anxiolytics remove anxiety, so that such as benzodiazepines, right? So you can provide sedation, for example, with propofol or fentanyl, but you're not really causing much anxiolysis. That is being achieved by the benzodiazepine. So these are straight from the RCDSO. So minimal sedation is, a pharmacological method of causing a little bit of relaxation for the patient. The patient's still able to follow your command, and their vital signs are not really affected. They're still maintaining cardiovascular and ventilatory function. Moderate sedation is similar, except the patient is a little bit more relaxed. We're given a little bit more medication, perhaps not even, and it is patient dependent, but patient is in a slightly deeper level of sedation than a minimal sedation. Again, no interventions required to maintain a patent airway, and the ventilatory and cardiac functions are maintained. So as we discussed, the inherent safety of minimal sedation and moderate sedation is that the patient is clearly conscious throughout. So you're doing oral sedation or even oral nitrous, and you say, "Hey, Johnny, can you turn your head towards me?" They should do that immediately. It's not like they're somewhat conscious or they've somewhat lost consciousness. So if that ever happens, you're probably a little bit past moderate sedation. And again, that is why minimal and moderate sedation, especially with the training that we take, are so safe. It's that because the patient is conscious throughout. Now, deep sedation is a pharmacological method of you're pretty much rendering the patient unconscious. However, you can bring them out of that unconsciousness by painful stimuli or repeated tactile stimulation. So if you say, Johnny, 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 even if you keep saying it, they're not going to respond. But if you shake them, or if you do a jaw thrust and hurt them, then they're going to say, what's going on? And oftentimes with deep sedation, sometimes they do require assistance in maintaining a patent airway. Not always though, and their cardiovascular function is usually maintained. Spontaneous ventilation is usually maintained. Sometimes it may be inadequate and they may need assistance. General anesthesia, on the other hand, you can, it's deeper than deep sedation. So you can hurt the patient, you can give them a jaw thrust, you can cut their skin, and they will not come out of that state of unconsciousness. They may react physiologically. You might make an incision and the patient may get hypertensive or tachycardic, but they are not going to be aware of it mentally and emotionally, and they will, if you ask them an hour later, they won't be able to tell you what happened. So let's briefly compare the different depths of sedation. So as we discussed, consciousness is maintained in minimal and moderate sedation, and it is not with deep sedation and GA. Purposeful response to verbal command, again, maintained in minimal and moderate, and absent in deep sedation and GA. Responsiveness. So as we mentioned, with minimal and moderate sedation, they will respond normally to verbal and tactile stimulation. With deep sedation, they will respond to painful or repeated stimulation. And with GA, they ain't responding to you no matter what you're doing, okay? Only their physiology will talk to you if you hurt them. Protected reflexes are obviously intact and maintained with minimal and moderate sedation. So if you're working and your assistant's not doing a good job of suctioning and water's going to the back of the throat, they might cough. If water's going down the wrong hole on their vocal cords into the trachea, they're going to cough it up. With deep sedation, it's depressed, so they might have a laryngospasm, which we'll talk about briefly. With general anesthesia, protective reflexes are not there. You could actually stick an endotracheal tube past the vocal cords into the trachea, which is one of the most stimulating things you could do to a patient. And under GA, you can obviously do that. Airway maintenance, again, with deep sedation, they might require intervention. With GA, they usually do, and they do not with minimal and moderate sedation. So I hope you can see the similarities with minimal and moderate sedation, right? All these aspects that essentially correlate to basically the patient's reflexes and how awake they are and how awake their physiology even is. It kind of shows you the safety of minimal and moderate sedation. Spontaneous ventilation usually is inadequate with GA. With deep sedation, it depends. Sometimes they require assistance, and usually it's maintained with minimal and moderate sedation. Monitoring is advanced for deep sedation and GA. In fact, the RCDSO has the exact same requirements for deep sedation and GA. For minimal sedation, it's very basic. For moderate sedation, it's slightly increased. It's the efficacy. So GA will work for any and all patients. I mean, think about it. You can do you could take out a patient's appendix under GA. So you could do any dental procedure while they're under GA. Deep sedation is similar. You can get away with almost anything with deep sedation, and minimal and moderate sedation, well, it really depends on the patient. So this is, remember I said that diagram I showed initially wasn't a very good image. this, on the other hand, is an excellent diagram because it's showing that, you have conscious, so minimal and moderate sedation, deep sedation, and GA. And it's showing that the route doesn't really matter. You can have oral medication, having the patient go into deep sedation. You can give a super low dose of propofol, intravenous drip, and have a patient just mildly sedated. Or you could give them enough and have them under general anesthesia, right? So the important thing that I want you to take away from this is that the route of administration doesn't really have much to do with the depth of the anesthetic. So again, we go back to this image because it's showing that. So where do we want to be where we're doing minimal and moderate sedation, which I assume is most, if not all, of the audience? Is that we want to be to the left of this red line. We want our patients to be clearly conscious during minimal and moderate sedation. So again, I hope you can appreciate that anesthesia is a continuum, and the dose that, let's say you give triazolam 0.5 or 0.625 to your 40-year-old adult who has, 8 beers a day, is on an SSRI, smokes 2 grams of cannabis, marijuana a day, and then you give that same 0.625 to your 80-year-old nursing home patient. I hope nobody's doing that. You're going to get a very, very different response, right? So basically, anesthesia and where you want to be, how deep you want to get the patient, really depends on these 3 things: the patient, their anxiety level, their preference. Some patients will tell you, oh, you know what, I probably am a little nervous. I just, for this filling you got to do, just give me something to just make me a little bit relaxed. And some people will say, you know what, no, like, I want to be out. I need to be asleep. Like, you're doing that endo, you're doing that filling, you're doing that cleaning. Believe it or not, these are things I hear. I got to be asleep. I don't want to know what you're doing. Depends on their medical history. So, I had a BMI 59 patient tell me, I want to be asleep for needed like a root canal, an extraction, and a couple of fillings. And I said, I'll get you as close to sleep as I can, but I can't guarantee you're going to be under a GA. So I treated that patient and went great. Afterwards, she said she had no idea. She told me she was asleep. I'll tell you, she was not fully asleep. I had her somewhere between moderate and deep sedation, but that's the beauty of benzodiazepines, right? In combination with, some other medications that I have the luxury of administering. But so basically, medical history is a big factor too. Procedure. So again, some patients will say, for this procedure, I want to be asleep. So that kind of goes back to preference. But it's also something we play a part of too, right? If you're doing, wisdom, I mean, you can do wisdom teeth awake. But I think that's something that a lot of providers, if you have the ability to give GA, patients, 90-95% of the time would prefer for impacted wisdom teeth. And I've done it both. I've done it awake and asleep, and it's way different when they're asleep. It's obviously much nicer when you're doing a procedure like reflecting the flap, removing bone in the posterior mandible, and sectioning a tooth. So proceed. I mean, doing a 3-6 MO is going to be, if you have a cooperative patient, ain't going to be so bad. Even if you have a very cooperative patient, getting that depth of anesthesia, just using local anesthesia for that 3-8 extraction, it's going to be a lot easier if they're asleep, obviously. And then provider training, depends on the training of the provider and the facility and the equipment. So what's important is that the patient response is variable, as we discussed, right? And we as practitioners need to be able to diagnose and manage the patient from deeper levels of sedation than intended. So if you're doing moderate sedation, you need to be able to treat the patient if they go into a deep sedation, right? So anesthesia and dentistry, often beneficial, sometimes essential. So, and this is from the college standards that were released in 2018. So actually, dentistry is one of the only fields in medicine that we routinely expect patients to have procedures done without any form of sedation, which is great because, patients can tolerate it and they can just have their procedure under local anesthesia. Why not? I mean, for a cleaning or, filling, even myself, I've had fillings. I don't need to be asleep or sedated even. Some patients do, and that's totally fine. For root canal, I mean, I hope I don't need one, but if I do, I think I'd be able to tolerate that awake. But, some patients, and the way I think society's going, you probably find that there's anxiety disorders are much more prevalent, And, I find at least that we do need to provide a lot more TLC when dealing with patients in general. So I do think that there are going to be, going forward, higher requirements for minimal, moderate sedation, deep sedation GA in dentistry. So these are the indications that we're going to go into a little bit more detail. So obviously dental phobia and anxiety, pediatrics of pre-cooperative age, invasive surgery or significant dental treatments, patients with intellectual and physical disabilities, patients with a severe gag reflex, patients who are medically compromised, and situations in which local anesthesia is either ineffective or contraindicated. So dental anxiety, obviously, we all know what it is. It's the emotional state that our anxious patients have, and the fear is that activated response that they feel when they encounter a dental situation. And obviously, patients who have dental anxiety will oftentimes experience dental fear while at the dentist. And a phobia is a marked level of dental fear, which creates considerable emotional stress for the patient. It's actually a mental disorder. Well, phobias are categorized in the DSM-5. And essentially, dental phobia will lead to dental avoidance and ultimately bigger dental issues. And I mean, we all know, right? We have some patients that say, oh, I just can't stand the smell or just the sound of the drill. So dental anxiety is multifactorial. I've heard all these things. I don't like the smell of the dental office. I don't like the sound of the drill. I had a dentist who was really mean and they made me feel like, I was worthless. I've actually heard someone say that. The patients say that I feel vulnerable. I'm lying back, my mouth open. I have no idea what's going to happen. I have no control. I don't know what's going to happen next. Feeling of danger, and a lot of times past experiences, negative past experiences at the dentist. So again, basically dental anxiety, the outcome is it can lead to dental avoidance and then emergency dental visits. And the most recent, I know it's a little dated from 2005, but Dr. Brian Champagne did a study, a Canadian study, and he found that 10% of the population is somewhat afraid of the dentist, 5% have a high dental fear, and 7.5% have missed dental visits in the past due to anxiety. And 50% of the patients in the high dental fear group have missed their dental visit due to anxiety. So that's probably the most common indication for sedation and anesthesia in dentistry, obviously, is dental anxiety. And then this is also a big one, pediatrics. So, if I have a chance to put a picture of Keon, my little guy, I'm going to do it. This is years ago. This was, I think he was not even a year old here. So now, thankfully, this is not Keon's mouth, okay? Basically, this is not pleasant, obviously. I do see this a lot. I see a lot of this. And it's unfortunately, pediatric patients who are uncooperative, who have, uncooperative age-appropriate behaviors, who have extensive dental treatment, such as this one, who may have special needs, who may have acute situational anxiety, they may have immature cognitive function, or they may have disabilities. So these are, the different classes of pediatric patients who may benefit or may require sedation and GA for their dental treatments, right? So again, rampant decay, early childhood caries. Thankfully, I don't see this every day, but sometimes I do, 10 times a year, perhaps. There was one kid last year, unfortunately, I think this kid was 4.5 or 5, and we kept his 5.3 and 6.3 with stainless steel crowns, extracted 5.5, 5.4, 5.2, 5.1, 6.1, 6.2, 6.4, 6.5, and the mandibular molars too. And we were able to keep his lower mandibular primary incisors and canines as well. I think I've heard of colleagues having to take out all 20 baby teeth. Thankfully, I haven't yet, but yeah. So this is, this is early childhood caries, right? In Canada, pediatric patients from a low socioeconomic status, rural communities and Aboriginal communities, we know that those are the patient populations that have the highest rates of ECC. So this is, these are different forms of restraints, not pleasant for any parent, any provider, any patient, first and foremost. And basically the new studies, not even new, the studies in the past like 10, 15 years show that deep sedation and general anesthesia for pediatrics is preferable by parents to any kind of restraint, either passive or active. And that's because these techniques can enhance dental anxiety. As a matter of fact, I mean, I see a lot of adult patients who are, severely anxious at the dentist. And majority of these patients will tell me, I had a really bad experience as a child, as a teenager. And that's really what we want to avoid, right? As a matter of fact, in Canada, pediatric dental surgery under general anesthesia is the #1 reason that children have GA. So dental. So children 6 and under, the #1 reason they're going to sleep in Canada is to get their teeth fixed. #2 reason is myringotomy and tube insertion, so ear tubes. #3 reason is tonsillectomy. So you can see how common it is, and for good reason. We know how common ECC is. We know how beneficial and essential GA is for treating early childhood caries in an atraumatic way. And we also know how safe general anesthesia and deep sedation are for dental procedures by qualified providers. So what about the safety of, let's say your child needs anesthesia to get their teeth fixed, or as a matter of fact, for any procedure, for tonsillectomy, for myringotomy and tube insertion. So if you or any of your friends ask about this, I would suggest you direct them to a website called Smart Tots. There's a lot of information there. But what we do know is, there's a lot of studies conducted to look at the safety. When I say safety, I'm talking about neurodevelopment and neurocognition. So, as a parent, naturally, you're going to be concerned, if my kid's going under, is that going to affect their brain? And there's 3 big studies, the most recent one being the GAS study, that have looked at, there's 3 high quality RCT studies looking at this topic. One of them is called the GAS study, one of them is called the PANDA study, one of them is called the MASK study. And the most recent one is this one that I'm presenting to you here. And that's a high quality RCT throughout, 28 hospitals across 7 first world countries, including Canada. Looked at 722 patients undergoing hernia repair as an infant, so under less than 1 year of age, for 1 hour anesthetic. And they were classified into an awake with regional anesthesia, because you can actually provide complete local anesthesia for this procedure, or a general anesthetic. And then they followed up these patients and they assessed their IQs at age 5, as well as a number of other assessments. And they found that basically there's no difference. There's no difference in their IQ levels. There's also no difference in developmental issues such as ADHD and autism. And if this is a topic that interests you, I suggest you visit. Actually, I summarize everything on my website. You can look it up. You can look up the GAS, PANDA, and MASK study if you want to look at the full depth studies. But if you go to 416sleepdentistry.ca, in the about anesthesia section, and the reason I've done this is parents ask me all the time, I've tried to summarize it into a way that patients and parents would be able to really understand, what do these studies mean. And thankfully, that evidence is that, especially after 3 years of age, a single exposure to anesthetic is really not going to have any effects on your neurocognition and development. That's what all the highest quality levels of study that we have show. Now, if a patient is undergoing numerous GAs, a pediatric patient, typically under 3 years of age, for example, cancer patients who need bone, spinals and bone marrow biopsies and bone taps and whatnot, then the studies show that there could be some neurodevelopment issues and neurocognition could be affected. But for single exposure, the consensus is that it is not. But again, if your child or a loved one's child needs anesthetic, check out smarttots.ca, and all the information is there. So hopefully that was helpful. I know parents might ask you, and if they ask you about the safety of catastrophic events, I don't have this in my slides, but parents ask me this all the time too. They say, well, what's the risk of, God forbid, something really bad happening under anesthesia? So we have 2 U of T studies. One of them was just published 2018 by my colleague, Dr. Al-Moafi. Dr. Nakansa did the other one about 20 years back. And the risk of experiencing a catastrophic event, such as death or brain damage, for general anesthesia or deep sedation for dental procedures in Ontario is reported to be roughly 1 in 1 million. So the risk isn't 0, but thankfully the risk is extremely low. The risk of that same patient experiencing a catastrophic event on their drive to your office or on their drive to work is much, 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 much higher. than it is to have a catastrophic event under deep sedation or GA. So, hopefully these are some, parents ask me this all the time, and if you do sedation, then hopefully this is of use to you. Now, what about invasive surgery or significant treatment? Well, really, it's patient dependent, right? So comprehensive full mouth treatment, maybe do they need to go to sleep for that? Maybe just surgical procedures, periodontal procedures, restorative, endo, scaling. Believe it or not, some patients hate it and they say, oh, you know what, if you're doing my filling, can you do my cleaning too while I'm asleep? Because I really don't like to have cleanings and I don't like the feeling of the scaler on my teeth. Again, basically, it's patient dependent. So intellectual disabilities like autism, trisomy 21, cerebral palsy, Angelman syndrome, DiGeorge. So basically, these patients usually who have developmental delays are not going to be cooperative at times at the dentist. Some may be, especially some Down syndrome patients are very cooperative. So again, it's patient dependent. So what about physical disabilities, like patients who have had strokes or who have tremors or Charcot-Marie-Tooth, multiple sclerosis, hyperthyroidism? And I put hyperthyroidism there because these physical disabilities, these patients typically have uncontrolled movements, tremors sometimes, and they're either unable to keep their head still or unable to keep their mouth open. And oftentimes these patients will require some level of sedation for their dental treatment. What about that? I mean, this is one of the main reasons patients get referred to me, severe gag reflex. We all know what it is. I mean, we know that the sensory response is through the glossopharyngeal nerve, the motor response is through the vagus nerve, and I guess the hypoglossal nerve, because that tongue thrusting motion, that's through the hypoglossal nerve. But that pharyngeal constriction, that's through the vagus nerve. And we can abolish that obviously with deeper levels of sedation. What about patients who are medically compromised? So the reason that I sometimes get patients who are very medically compromised for sedation, you might think it's counterintuitive because you may think, well, they're really sick. Can they really have sedation? But I'm not pumping these patients with propofol and decreasing their blood pressure and putting them in a GA just like that, right? What we're doing is we're managing their physiology. We're reducing their stress, and we're really reducing their endogenous release of epinephrine, right? And the reason we're doing that is, let's say you have a cardiac patient. You really want to keep their heart and their blood vessels happy. So you want to keep their heart working not too hard, because we don't want to predispose the heart to hypoxia, because if it works faster, the oxygen requirements will go higher, which puts you at risk of ischemia. And with sedation, you can obviously, if they're anxious, you can decrease the amount of endogenous epinephrine that's released. So at rest, typical, I mean, this is very, not precise, but you can think of the release of epinephrine from an endogenous, like your endogenous epinephrine relief, to be about 7 micrograms per minute. And if it's induced, that can go up significantly to like 280. So this is just showing plain 2% Lido being administered and plasma epinephrine release. So that's all going to be initially endogenous epi's release because it hurts, and then it goes down. And with epinephrine, you're getting the bit of endogenous release from the pain of the injection, but more so you're getting it from the actual epinephrine that's in the cartridge. And you probably heard limit epinephrine to roughly 40 mics for cardiac patients, which is the equivalent of just over 2 carps of 2% lidocaine with 1 in 100,000 epinephrine. How about patients who have either ineffective local anesthesia or contraindications to local anesthesia? So, I mean, these are some of those examples. Patients with pseudocholinesterase deficiency. So you can give them lidocaine, just avoid ester local anesthetics. Don't give them procaine. Don't give them topical benzocaine. And the concern here is that these patients may have impaired metabolism of ester local anesthetics. What about allergic reactions? So some patients, I've seen some who are truly allergic to local anesthetic itself. They've been referred to me because I have to put them to sleep and I literally can't use local. And it sucks because if you have to do an extraction, I obviously, even when you're asleep, still use local, but in cases like this, you can't. So when a patient is truly allergic to a local anesthetic, which is very rare, we know that esters are more likely to be the culprit, and that's because they have a metabolite of PABA, which is similar to methylparaben. Patients can also be allergic to metabosulfite, which is an antioxidant added to local anesthetics that contain epinephrine to prevent the biodegradation of epinephrine by oxygen. And methylparaben, I mean, it's not really related to local anesthetics and dentistry because we don't use multi-dose vials, but that's a preservative added to multi-dose vials. What about ineffective local anesthesia? This is another reason that patients, I do end up seeing patients who need deeper levels of sedation. And that's because they might have a very inflamed tooth. So we know that if you have a hot tooth and you have acidity around the site, it's going to be hard to freeze that tooth, right? Because you need the unionized form of local anesthesia to pass through the tissue barrier and go and elicit its local anesthetic and sodium channel blocking effects. But in a site of infection, where the pH is lower, you're going to get a lot more ionized local anesthetic, which won't be able to cross that barrier and won't be able to have its local anesthetic effects, right? You recall the Henderson-Hasselbalch equation? That's basically what I'm talking about there. Also patient apprehension. So, some patients are just so nervous that local anesthesia doesn't work well enough. This is a big reason: anatomic variability, accessory innervation, intravascular injection, so the local is not staying in the site, but being administered systemically, and then incorrect technique. So the provider is not landmarking correctly, not injecting correctly, and whatnot. So these are some anatomic variations. I'm not going to go into details, but, fascial linings that basically prevent the local anesthetic from going to where it's supposed to. Accessory innervation for the mylohyoid, long buccal nerve, great auricular nerve. Patients who may have bifid mandibular canals, you may not be able to achieve a good intraalveolar nerve block, mandibular nerve block there. And patients with mandibular prognathism, usually the insertion of the mandibular canal is a little bit higher. So when we landmark the way we're used to, we end up often missing and not achieving good mandibular blocks in these patients. So if you have a patient who you have trouble freezing, what I suggest is take a good medical history of the patient, ensure that there's no contraindications to NSAIDs. And if there aren't, then give them a high dose of pre-op NSAIDs, 600, even 800 of ibuprofen about an hour before. But again, you want to confirm they have no renal disease, no diabetes, which may in turn have renal disease, no bleeding disorders, no GI ulcers. Ensure they can have a higher dose of NSAID. You want to take advantage of nitrous oxide because it itself has some analgesic properties, and you want to use a concentrated local anesthetic such as articaine, even for a block. I mean, I know that we may have heard don't use articaine for blocks, and there's some evidence for that. I was given a talk at the ASM this year, and I presented some new literature, not even new, relative, it's like a few years ago. It's the highest level of evidence. It's a meta-analysis comparing lidocaine and articaine blocks and paresthesias afterwards, and no difference. And when I brought that up at the ASM, some people were very confused, and they said, the college has released a statement saying I think the wording is something like the prudent practitioner should consider the scientific literature or evidence when just determining whether to use 4% articaine for mandibular blocks. Don't quote me on that. It's something like that. And, it makes sense. The prudent practitioner should consider the literature for anything they do, right? If you're doing grafting, you want to consider the evidence of, allograft versus xenograft, or whether you should even be grafting if you have like a four-wall, whatever, right? So a prudent practitioner should practice evidence-based medicine and dentistry, and that's what we do. So I went ahead and I sent that article to the college, and they thanked me, and they said, we'll add it to our database of articles. Now, I'm not saying go and block everybody with articaine, but I'm saying if you have a patient who doesn't, who you're having difficulty achieving a mandibular block, review their medical history, and for this case, perhaps consider a concentrated local anesthetic, nitrous oxide to take advantage of the analgesic properties, and a preoperative NSAID about an hour before to also take advantage of the analgesic properties there. So this is a little bit dated again. It's from 2005, but it's the most recent study that we have that shows the prevalence and preference of deep sedation and general anesthesia for different procedures. So you can see that, exodontia, we're doing pretty good. This is a proportion increase. So prevalence and preference. So 21% of patients are being sedated, deep sedation or GA for exodoncia, while 46% want to be. So it's a 2 times increase. Periosurgery is the big one. So I think periodontists probably know a lot of their patients do request deeper levels of sedation. Endo's a big one. Restorative and even cleaning, like I mentioned, a lot of patients do want to be, believe it or not, sedated for that. So that's kind of one aspect of the talk. Now I do want to talk a little bit about antibiotic prophylaxis. The reason being, this is a topic that colleagues in dentistry often ask me about enough. Evidence is perhaps sometimes changing. So let's talk about antibiotic prophylaxis for total joint replacement as well as for infective bacterial endocarditis. So for total joint replacement, there's a consensus statement from the CDA for dental patients with total joint replacement. So the Canadian Orthopedic Association, the CDA, and the Association of Medical Microbiology and Infectious Disease have a consensus. And basically, you do not, the short of it is that you don't need to do antibiotic prophylaxis for patients with total joint replacements. And here are the reasons. Most transient bacteremia of oral origin occurs outside of dental procedures. Significant majority of prosthetic joint infections are not due to organisms found in the mouth. Few prosthetic joint infections have an observable and clearly defined relationship with dental procedures, and there's no reliable evidence that antibiotic prophylaxis prior to dental procedures prevent prosthetic joint infection. So basically, don't worry about it. If a patient tells you, no, I need it, and their orthopedic surgeon wants them to, sure, talk to the orthopedic surgeon, be like, can you please prescribe it? I'm a prudent practitioner and I practice evidence-based dentistry, and the recent evidence says that we don't need to. So again, patients shouldn't be exposed to the adverse effects of antibiotics, and you essentially don't need to do it, okay? What about for bacterial endocarditis, infective bacterial endocarditis? So there are 4 classes of patients, and you probably know this, and this is review, I'm sure you know this. So these are the 4 classes of patients who require antibiotic prophylaxis for infective bacterial endocarditis prior to their dental procedures. So that's patients who have a prosthetic cardiac valve, who have had previous infective endocarditis, who have 3 classes of congenital heart disease. So either unrepaired cyanotic congenital heart disease, including palliative shunts and conduits, patients who have completely repaired congenital heart defects with prosthetic material or device within the first 6 months, patients who have a repaired CHD with residual defects at the site or adjacent to the site of a prosthetic patch or prosthetic device, and cardiac transplant patients who have developed cardiac valvulopathy. So not even heart transplant patients don't need it unless that heart transplant has developed a cardiac valvulopathy. So, I mean, we're really not dealing with a lot of these. I mean, the CHD, this is like a sick kids patient who has either cyanotic congenital heart disease and they're undergoing their dental procedure prior to their repair of their congenital heart disease defect, or who they've had the surgery within the first 6 months and they're having a dental procedure. I mean, I don't know how many cardiac transplant patients we're seeing who have developed cardiac valvulopathy. Certainly we'll see some patients in these first 2 classes, and those are the cases where you want to go ahead and give infective bacterial endocarditis antibiotic prophylaxis. These are the procedures that require antibiotic prophylaxis. So anything that requires the manipulation of the gingiva, the periodontium, and the periapical tissues. So, obviously surgery or perio procedures, endo instrumentation, antibiotic fibers or strips, subgingival placement, initial placement of ortho bands, but not brackets, intraligamentary local anesthesia infections, and prophylactic cleaning of teeth or implants where bleeding is anticipated. I don't know anyone who can do a cleaning and not get bleeding. So essentially, to me, if you're doing a cleaning, you got to do that as well. It doesn't include local anesthetic placement unless you're going through a site of infection. And these are the medications you can use. So basically, through the PO route, you could give amoxicillin if they're not allergic. Adult dose is 2 grams an hour before. Pediatric dose is 50 milligrams per kilogram an hour before. If they can't take oral medication, you can give ampicillin. Same doses, 2 grams for adults, 50 mg per kilogram for kids. If they're allergic to penicillin, the PO route, you can give Clinda, cephalexin, or you can give azithromycin or clarithromycin. Here are the dosages there, adult and pediatric, and the time frame for PO is again an hour before. If it's through the IV route, again, it's within 30 minutes. And if they're allergic to amoxicillin and they can't take oral medications, well, then you can take Clinda or cefazolin, and here are the dosages for that. Okay. All right. So now I want to go on talk about how we can achieve sedation and anesthesia. So, you hear people say, oh, do you do oral sedation? Do you do IV sedation? And really, the reason I put this here is that, as we discussed, the route doesn't equal depth. So you can again see that you can use different routes and you can get any depth. You can use oral route and you can get conscious or unconscious, right? So here are some of the routes of administration of medications. You can have inhalational, oral, IV, sublingual, and I bolded those because those are the ones we commonly use in dentistry. Hopefully, no one's using the rectal route often. Intranasal route, I mean, you might. Some people might use tetracaine ester local anesthetic to achieve pulpal anesthesia from the upper 3 to 3, right? You can anesthetize the anterior segment of the superior alveolar nerve, a branch of the infraorbital nerve, through an intranasal tetracaine local anesthetic, and submucosal and subcutaneous. That's another route as well. So we're just going to do the same thing like we did before and compare the different administration routes. So the ability to titrate. So when I say inhalational here, I'm talking about nitrous. I'm not talking about like vapor anesthetics because those will cause general anesthesia. So IV and inhalational, excellent. You can titrate very well. With oral, you really can't. And I mean, I'm sure you all know that no stack dosing, no titration of oral medications. So this is this chart is basically showing male and female, and it's showing an oral dose of diazepam 15 milligrams being administered. And here you can see the variability in local plasma levels after 3 hours, right? So these are just patient numbers. You can just think of patient A, B, C, D, E, F, G. And after 3 hours, look at this variability. It's huge, right? So this is why we definitely don't want to titrate oral medications, right? What about onset? So IV and inhalation, we know it's rapid. You put on the nitrous, you turn it up to 50, 60%, whatever. And within a minute, the patient can, you can achieve sedation. Same with IV. With oral, we all know it's a little different. They got to come in an hour before. You want to give them, give them the medication in your office. If you're giving, I mean, that's really the best way to do it. We're going to talk about that shortly as well. So when you do give an oral medication, this is what's happening. First, it's being absorbed from the GI tract. Then it's still being absorbed, distributed to its central site of action, the brain. And it's also being eliminated. And then afterwards, it's predominantly being eliminated. This says time hours, but I mean, it could be 10, 20, and 30. It depends on the medication and the pharmacokinetic properties and pharmacokinetic properties of that medication, right? What about duration? So inhalational is controlled. Again, you can turn it nitrous on, turn it off, it's gone. Oral and IV are prolonged. It's going to hang around longer, right? Now with IV, really it depends because some medications like remifentanil, you can infuse it, you turn it off, and it's gone. And that's because it is metabolized by non-specific plasmasterases. But anyway, we're not going to focus too much on that. What about the ability to reverse? Again, inhalational, easy. You turn off your nitrous, 100% oxygen, and the effects of nitrous are gone. For oral and IV, it's obviously a little different, right? It's much harder to reverse an oral and IV drug. Need for escort home? No, you don't need it for nitrous. Put a star there in case, if you're using, again, vapor, then obviously you do need a need for escort home. But for our purposes, if you're using nitrous oxide, you obviously don't need a ride home. Patient can drive themselves home because we can reverse it and the duration is controlled for nitrous, right? For oral and IV, you need a ride home, obviously. Technique difficulty. So inhalation is easy, put a nasal hood on. Oral is very easy, take this pill. IV, well, some patients aren't gonna like the IV, which is why I put fair for patient acceptance. So, a lot of teens will tell you, oh, I hate the needle. Inhalational is good and oral is very good. Few people, except for some kids, I guess, are going to really resist with an oral medication. Efficacy. So inhalational oral, I put moderate. IV is excellent because you can give so many medications through the IV route. General anesthetics even, right? So how do we achieve sedation and anesthesia in the dental office? Well, we can use inhalational medications, we can use oral medications and IV medications. So inhalation, obviously nitrous and vapor anesthetics. Oral, I mean, barbiturates are pretty historical. No one's really using those. Of course, everyone's still using benzos, antihistamines, perhaps. I don't know how many people are using oral opioids, and obviously IV opioids, IV benzos, and IV general anesthetics. But the big one is obviously this one, right? Benzos, so triazolam, temazepam, midazolam, diazepam, lorazepam, alprazolam. Take your pick, whichever you want to use. They all do the same thing. They're all excellent anxiolytics, and they have 5 actions, which you probably recall, right? Anxiolysis, sedation, amnesia, muscle relaxation, and they have anticonvulsant. Anticonvulsant effects as well. So let's talk a little bit about discharge criteria. So basically, if you're discharging your patient after the sedation appointment, they have to be conscious, alert, and oriented to person, place, and time. So know who they are, what their name is, where they are, and what week it is. The vital signs must be stable. They should be ambulatory. They should be increasingly alert, and they should have a responsible adult to accompany them home. All right, so now I'm not going to talk much about sedation emergency. I have a course on medical emergencies and sedation emergencies. Going to talk about the big ones, and airway. So that's the biggest thing for sedation emergencies, right? So you can have airway obstructions, and you probably know the most common source of airway obstruction is the tongue falling back in the posterior pharynx and blocking this patient from being able to breathe effectively. So what do? You do a head tilt chin lift, right? You do that, you typically will relieve the obstruction, the tongue, and the air can come in and go into the trachea. If you have a patient with severe OSA, this probably ain't going to work. So then you can do the jaw thrust, which again may not work, but this is kind of like the step past head tilt chin lift. This is going to, you're doing a head tilt chin lift naturally when you do a jaw thrust, but you're also displacing the whole mandible and tongue forward by doing this action. When you do it, it's also stimulating and it hurts, which is another advantage of it. Because if you have, let's say you're doing moderate oral sedation with nitrous or moderate parenteral sedation, and you're like, shoot, my patient's under deep sedation. What you can do a jaw thrust. Not only are you going to open up their airway, you're going to hurt the patient, which is good because you're going to stimulate them and get them out of that deep sedation and get them to respond. Remember, deep sedation, they will respond to painful stimulation, right? So this is an oral airway. That's another medical device you can use to bypass the potential obstruction site of the tongue. Laryngospasm. So this is a medical emergency. And basically, these are the vocal cords that's going into the trachea. So when we breathe, air goes in to the trachea and the expired air comes out. And this is one of the most sensitive parts of the human body, right? So anything touches here, cords are going to close. That's our protective reflex to prevent aspiration. We don't want anything going, except air really, going into our trachea and into our lungs. So if you have a patient perhaps under deep sedation who's, not quite under GA, not quite deep enough, and your assistant's not doing a good job suctioning, or you're doing an extraction, it's bleeding, they're not suctioning well, you're cutting the tooth, you're using too much water, it goes back, the water or blood touches the cords, trickles onto the cords are going to shut, the patient's going to do that. It looks like they're coughing, but air's not moving. So that's a medical emergency. And if you're doing IV sedation, deep sedation, parenteral moderate IV sedation. See, I made my own mistake. I said IV sedation. Or if you're doing deep sedation or general anesthesia, you obviously need to know how to very quickly and effectively manage a laryngospasm. Bronchospasm is airway obstruction, but lower airways, right? So you get that expiratory wheeze, what happens a lot in asthma. Other emergencies, so you can have cardiovascular emergencies like angina, myocardial infarction, bradycardia, hypotension, arrhythmias, and cardiovascular arrests. And again, we talk more about these in our medical emergency lectures. Anaphylaxis. So there's 3 life-saving medications. You obviously want to call 911, stop your allergen source. And this patient needs to get epinephrine. If you have an EpiPen, give that to them. If not, you can draw it up from a vial. To an adult patient, you want to give 0.3 to 0.5 milligrams. You can give it in the deltoid, the quad. To a pediatric patient, you want to give 0.15 milligrams. If you're giving it IM, the patient will need oxygen and fluids. So they get release of vasodilatory chemicals that causes basically the peripheral system to shut down, and you get all the intravascular fluid going into the tissue space. So that's why they get edema. So again, epi, oxygen, and fluids are going to save the patient's life when they have an anaphylactic reaction. And you can also consider an antihistamine and steroid. Those aren't going to save the patient's life immediately, but they are part of the algorithm. Hypoglycemia, obviously the patient needs sugar. You want to give them about 1 gram per kilogram. So, give an adult about 50 grams, 30 to 50 grams if they're able to tolerate oral medication. If you have an IV, you can give them IV dextrose. If you don't and they're unconscious and you can't get an IV, you can give them IM, intramuscular glucagon. The essential emergency medications are oxygen, epinephrine, ASA, salbutamol, antihistamine, and nitroglycerin. Okay, so everybody who does or does not do sedation has to have at least these 6 medications. Okay, so that's essentially my presentation. I have a section on RCDSO. I do want to just pause it here though. The RCDSO section can be lengthy. I mean, it's essentially I'm reviewing the standards that came out in November 2018. The college should be releasing new standards in the next few years. There have been some updates, but you're probably familiar with them now. I can highlight the key ones, but I might just give an opportunity to TMFD to see if they want to jump in here and see if if there's any Q&A, or if we don't have to go through the RCDSO sections. I can highlight the key parts. I won't be able to cover all the slides, obviously. I don't know if Carla wants to jump in here. Did you want to do the Q&A part now?
I think you have a few minutes.
Do I? Okay.
We only have about 2 questions in the Q&A so far.
Oh, so why don't I go on to the parts of the RCDSO that I think are worthwhile mentioning. Okay. So this is the new standards. Basically, this slide just shows that if you're doing a set level of sedation, you need to be able to rescue the patient if they go into a deeper state. So if you're doing moderate sedation, you have to be able to manage a patient who goes into deep sedation. So it's the standards. There's standards for minimal and moderate sedation and deep sedation and GA. These are the standards that all modalities have to basically follow. So you got to have the correct training program, correct dental facility, your codes, the size, the layout of the building. You will have to do a medical history. You have to do an ASA assessment. Patients under 12 years old, basically no parenteral moderate sedation by GPs. You can't really do that anymore if you're a GP. Patients under 3-year-old, no oral sedation even, under 3 or under 15 kilograms. And under 12, it's strongly suggested to not do even oral moderate sedation for general dentists. Excuse me, unless you're a pediatric dentist or a patient with, or provider with a deep sedation or GA license. ASA 4 patients that can't have sedation or GA in a dental office, it has to be in a hospital. Obviously, no one's seeing ASA 4 patients. And only a dentist or a physician can administer sedation or general anesthesia. You have to have the adequate emergency training, adequate CE. You have to have the correct number of sedation cases. You must calculate the local anesthetic max doses, and tier 1 and tier 2 reporting is new as well. So this is CE, right? So for minimal sedation, you just need your minimum 5 cases. For oral moderate sedation, now anyone doing oral moderate sedation, with or without nitrous, needs a minimum of 6 hours of continuing education related to oral moderate sedation every 3-year period, and a minimum of 5 cases. If patients under 12 years are treated, a minimum of 5 cases must be 12 and under. They do suggest not doing oral moderate under 12, but definitely not under 3. You can still do oral moderate under 12. Just need to have your cases, minimum of 5, and have the correct CE and have the correct training, okay? For parenteral moderate sedation, you need a minimum of 12 hours of CE and a minimum of 10 cases. And for deep sedation and GA, again, 12 hours of CE, and you got to have your cases as well. And if you're doing ACLS and PALS, that does not count as a CE for this section. You actually need to have continuing education outside of BLS, ACLS, and PALS. Tier 1 and tier 2 reporting somewhat new. So tier 1 event, you got to report to the college within 24 hours. If there's a serious event such as death of a patient within the facility, death of a patient within 10 days of a procedure performed at the facility, or transfer of a patient from the facility directly to a hospital for care. So if God forbid any of this stuff occurs, you need to report immediately within 24 hours in tier 1. Tier 2 event, you have 10 days to report, and that's if you have an unscheduled treatment of a patient in a hospital within 10 days of a procedure performed at your setting under sedation. If you use a benzo or opioid antagonist, so if you're giving naloxone, for example, flumazenil, or any serious cardiac or respiratory adverse events requiring administration of the medication for its management. So we all know you got to have a drug register, keep it locked in a secure area. It's basically new that anyone who administers nitrous, you must have authorization from the college effective April 2022. And all facilities where nitrous are administered are subject to random on-site inspections effective April 22. The other stuff's the same as before. You have to have fail-safe, scavenging, reserve oxygen, supply. Your charting is the same, right? This is just a reminder, hygienists and assistants can administer nitrous. This is your nitrous minimal sedation record, which I'm sure you all know. You have to review this is a minimum. Have to have a patient medical history, obviously, pre-op blood pressure and pulse. You have to have your total flow of nitrous and oxygen, your percentage of nitrous, and the duration of administration of nitrous oxide. Duration of administration of 100% oxygen at the end of the procedure. So you want to do it for 3 minutes, and then a notation regarding the patient's tolerance to the procedure. And that's so that in the future, you know how it went, if you need to use the same method or if you need to change things at all. So again, this is the same. We discussed all this. You have to have for minimal and moderate sedation, you need to have authorization from the college. All dentists administering oral minimal sedation for patients under 12 must provide care that meets all requirements for oral moderate sedation. Under 3 or under 15, basically you have to be a pediatric dentist or you have to have a deep sedation or GA license. And if you're doing minimal oral sedation, only a single oral sedative is allowed, no other sedative medication by any route. These are the doses for minimal sedation, which you're all familiar with and you can refer to in the college standards. And you can't give an opioid or chloral hydrate for minimal or moderate oral sedation. Obviously, patient needs to be MPO for 2 hours. You have to have consent, correct monitors. And this is all the stuff that we know and are familiar with. So nothing really new here, except for the tier reporting, which we discussed. Oral minimal sedation hasn't changed, right? We're going to go over a sample shortly. We'll go over that shortly. Oral moderate sedation training. So you have to either have approval from the college before 2012 or have the adequate CE. Only single sedative PO drugs like benzos are allowed. You can only give 2 sedative PO drugs if you have a deep sedation GA license, if you're a pediatric dentist, or if you have a moderate sedation IV qualification license. Single PO drug with or without nitrous is allowed, obviously, for oral moderate sedation. And again, oral moderate sedation under 3, you have to have a deep sedation or GA license or a pediatric dentist, and you have to have your PALS as well. That's pediatric advanced life support. These are the moderate sedation doses and dose ranges, which again, we're familiar with and we can refer to on the standards. Under 12 patients, if you're doing moderate PO sedation under 12, says additional training is required. You can use Versed 0.5 milligram per kilogram. You've got to max out at 15 milligrams. Diazepam, same thing. Hydroxyzine, 1 milligram per kilo, maxing out at 30. And pediatric dentists may, in rare occasions, exceed these doses and give up to 20 milligrams of Versed and up to 50 milligrams of hydroxyzine. No additional oral sedatives are allowed. So again, no stacked or incremental dosing. Don't exceed the maximum levels mentioned for minimal or moderate sedation. This is just saying that obviously any dentist who's administering sedation must be qualified, must be in good standing with the college, must have authorization from the college, but ultimately the responsibility does share with the facility owner as well. Okay, so if you're the provider of the facility, you need to ensure that yourself, your facility's up to standards, and anyone providing sedation is also up to standards of the college as well. Oral moderate sedation, again, you're familiar with all this. You have to have access for emergency stretchers, backup suction, lighting, monitors, ASA assessment, MPO, A642 rule. So full fatty meals, MPO for 8 hours, light meals such as toast, 6 hours, human milk, 6 hours, breast milk, 4 hours, and clear liquids like water or apple juice, 2 hours. You have to have consent. You have to monitor the patient, continuous SpO2 monitor recorded every 15 minutes, heart rate and BP intraoperatively every 15 minutes. You also have to have a pre and post-op heart rate and blood pressure, and you have to record the respirations every 15 minutes, but you're obviously monitoring it continuously. Sedation record we'll talk about briefly. Discharge criteria, which we are aware of, we discussed. You might want to have a written post-op instructions, and you might want to include, well, you need to have written post-op instructions, and you might want to include social media in today's day and age, right? You might want to say, don't go on Instagram for the first 12 hours, because I heard of a case in the States where after sedation, a patient posted something on social media, they regretted, they wanted to sue the dentist. So just something to consider, right? I mean, there's unfortunately some litigious patients out there, so just something to consider. Reversal agent, if you administer it, you got to observe the patient for a longer period, and now you got to file a tier 2 report. And the practitioner should never be alone during treatment. So in rare cases where the practitioner finds that the BP or pulse oximeter would be an impediment to the management of the individual patient, you can choose to not have those monitors, but that it should not be standard practice. And the college, if they do find that you're doing that, they're probably going to go through your records very, very thoroughly. So I really advise you not to do this unless you absolutely have to. And if you are doing this, I think the reason they have this here is this is going to be for a patient that's really not sitting still. So they're clearly conscious, and they're not, they're not tolerating the SpO2 or the BP cuff. So, but anyway, that should not be common practice. Sedation equipment, obviously you got to have your sedation records. Equipment has to have a Health Canada license. You got to have the right equipment, full face masks. You have to have your emergency medications. And this is the record I want to show you guys. So this is actually available on the college. This is from the RCDSO. This is a sample oral moderate sedation record, okay? IV moderate sedation, I'm not going to go into too much details here. I don't know how many IV sedation providers there are here. We do provide a full 6 and 12-hour oral and IV sedation refresher courses to satisfy the requirements of the college. IV moderate sedation recovery. This is for sedation equipment. And yeah, pretty much this is what I wanted to talk about for the college stuff. This is a sample parenteral moderate sedation record, right? And deep sedation and GA, probably not going to go into too much details there. All right. Not much has changed there. One thing that has changed is the ratio of recovery supervisors are 1-to-1 if the patient meets 1-to-1 if the patient meets the criteria for deep sedation and GA. So 1 nurse to 1 patient if they're still asleep. And if they meet criteria for moderate or minimal sedation, you can have 1 recovery supervisor per 2 recovering patients. That is one of the changes too. Okay. Otherwise, nothing else has really changed. I want to thank you all for your attention. Hopefully nobody fell asleep there. I know deep sedation and GA, if you're not a pharmacology and physiology nerd like myself, it's not the most interesting topic. It is to me, obviously. So hopefully you found that interesting. I want to thank TMFD for the opportunity, and I want to thank you guys for being here with me tonight. All right.
Thanks, Dr. Soheil, for the valuable information. Now the floor is open for the questions. Please enter your question in the Q&A box, and it will be answered in the queue. I noticed that we already have few questions, so I'm reading one by one, and we go from that. So first question we have from anonymous attendee, and say, doctor has published paper on article that it can be used even for extracting upper molars without buccal anesthesis because its ability to pass through cancellous bone. My question, when do you use article? And he's also thanking for your excellent presentation.
Yeah, thank you very much. I'm not quite sure I understand the question, but I'll talk a little bit about articaine. So articaine is a 4% solution. We do know that it does have an increased depth and increased duration compared to 2% lidocaine. So that is why I mentioned in those cases where you're having ineffective local anesthesia, you might want to consider using a 4% more concentrated solution, supplementing with the analgesic effects of nitrous, as well as the analgesic effects of NSAIDs. So you would use articaine if you want to achieve a deeper level of block, as well as a slightly longer duration. You can also use bupivacaine if you want to get a very much longer duration. For example, if you're doing wisdom teeth extraction and you want to have your patient anesthetized for a prolonged period, because then you can take advantage of something called preemptive analgesia. Preventing pain in the immediate postoperative period is shown to reduce postoperative pain in the upcoming days as well. I'm not saying use articaine for all your blocks. That's kind of up to you. You should do what the college says, which is consider the available scientific literature, and I encourage everybody to do that.
Second question we have, if patient has given 40% nitrous for 1.5 hours, how long minutes would we have to give 100% oxygen so that there is no more nitrous oxide left in their body?
So if you recall, one of the advantages of inhalational nitrous oxide is the fact that it will very rapidly leave its site of action, the brain, and be expired. So when you go to 100% oxygen for 3 minutes, whether you have nitrous going for 10 minutes, 1 hour, or 3 hours, that nitrous will be completely eliminated from the patient's central site of action, the brain, as well as the patient's body.
You have another question that I can see the patient on methadone and some on oxydone, 180 per month due to back pain. What do you suggest for extraction of a first molar mandibular tooth?
Again, I'm not quite sure I understand the question. Like local anesthetic or like post-operative pain control? Because, local anesthetic, you just got to freeze the patient, use local anesthesia, lidocaine, articaine, bupivacaine, mepivacaine, whichever local anesthetic you want to use. This patient's, in the post-operative period, this is probably like a chronic pain patient. And these patients, unfortunately, are much more predisposed to post-operative pain, and it's harder to manage their pain post-operatively. So, if you're talking local anesthetic, use your local anesthetic of choice. And in the post-operative phase, I would suggest starting, following the algorithm. Start with high dose. You got first and foremost, you have to take medical history of your patient. And if there's no contraindications, max them out on Tylenol and an NSAID, and then slowly add in an opioid if desired.
Next question we have, even though I have license for oral minimal sedative, till date I have not used them on patient. How do I order these benzos from a pharmacy? And if yes, whose name is on the prescription?
Yeah. So you can order it pretty much from any pharmacy. It will be your name on the prescription. And that's why you have to have a record, right? A sedation record. So when you're going to order from a pharmacy, any pharmacy you want, if you're doing higher levels of sedation, I can suggest someone to you because they work with a lot of dental offices who provide deep sedation and GA. But any pharmacy, you're going to be the ordering physician, so it'll be under your name, but not as the patient, right? So it's going to go into your record, and then you're going to have a count when you get those medications, and then as you administer those medications, your count's going to decrease because you're going to say how much. Just if it's all in the college standards, you have the date, patient name, how much was administered, if anything was wasted, and then you always have to have an end of day count as well.
Sure. Next question we have, how we can get more information on oral sedation refresher course?
I'll be happy to provide that information to you. I can provide my my personal email. It's can I write it anywhere, or can Carla, can you share it with them? If so, yeah, I mean,
Yes,
I can
please.
provide my cell phone and my email to you guys. If you have any questions about sedation, pharmacology, physiology, anesthesia, you know, definitely reach out. I'll be happy to answer any questions you may have. I always welcome questions after these talks, even, you know, in the future. Next, you have a sedation case coming up, you're stressed about it, call me and we'll chat about it, and I'll hopefully guide you through your plan for that case.
Sure.
You can enter your information in the chat box if you'd like, and everyone can.
All right, sure, let's do
extract
that.
it from the
Okay,
chat box.
so to hosts and panelists, I'll do that right now, and I can still answer the question too. I can answer the next question.
Sure. Sometimes patients show up at the dental office having been given an oral sedative by their MDs for a dental procedure. How do we handle this ethically and professionally, and who is responsible?
So it's the prescribing provider is responsible. So if their family physician has deemed that this is, you know, this is okay on their end, then you don't really need to worry. They're probably not going to give like a crazy dose. Usually they're giving, you know, pretty low dose of Ativan. So I wouldn't worry too much. If you want to be very prudent, you can go ahead and fill out a sedation record for, you know, or moderate sedation, even if you're doing minimal. But at the minimum, you should do minimal sedation record, and you should, in your documentation, mention that patient X was given medication Y by provider, you know, family MD, and this was the pre-op vitals and so on and so forth.
Next question, one more question about, can you tell me more about oral mediate sedation? Do you need an RCDSO form to fill for every irazepam given to a patient?
So, I mean, you don't need an RCDSO form, but you absolutely need a record. You always need a sedation record when you're doing oral moderate sedation. Or any level of sedation you're doing, you do need to document and have a record for that sedation, yes.
Next question is for minimal sedation, either nitrous or oral, other than the RCDSO's permit, do we need anything else? And once we get the permit, can we start right away?
You just need to have approval from the college, right? Sorry, my wife's just trying to grab something back there. Yeah, you can. You just need authorization from the college to do so. Otherwise, you just need to make sure your equipment is well kept, and you have it's up to date, and you have your records fulfilled. For oral, you need to also have authorization from the college. But for minimal, yeah, as of 2020, you just need to have the college know that, you know, your provider, your facility is administering nitrous. And before 2020, for minimal, you didn't even need to do that, but now we do.
Next question is the BP, etc. for kids for N2O, and that's a question mark.
Oh, okay. Yes, yeah, you do. You need to. So again, that note that I mentioned that said, in rare cases, you may choose to not use the blood pressure and SpO2. You got to document why. I highly suggest that does not become standard practice, but you can. And for kids, yeah, you need to, you know, anytime you're doing nitrous, you have to have a pre-op heart rate and blood pressure. And you need to have a post-op heart rate and blood pressure as well.
Next question we have, may I see your slide on recovery requirement after GA again? Is capnography required for oral moderate sedation? Is respiration monitoring without equipment acceptable? That is capnography, tracheal stethoscope as per the RCDSO requirements?
Right. Very good question. So if a patient is under deep sedation or GA, yes, you need capnography monitoring. For oral moderate sedation, you can monitor the respirations as you see fit, and you need to record it every 15 minutes.
Next question is, I perform lots of nitrous for kids, 26 years. Why BP on kids? Too hard to take? and how do you measure weight and height?
So in my office, I have a height chart, and we take everyone's heights because I'm calculating their BMI, and I have a scale, and they stand on that, and that's how I take their weight. And with respect to blood pressure on kids, I mean, that's what the college wants us to do, and it's good practice, right? You should have vital. Anytime you're doing a sedative on any patient, you should have vital signs, and heart rate and blood pressure are, very basic and easy vital signs to take. If a child or adult is having any sedation anywhere in a hospital, any setting, in a medical facility, their heart rate and blood pressure is always recorded as well. And by our college, we're required to as well. So I hope that helps.
That's all we question have this evening. Before we wrap up at the evening, I would like to turn over to Carla for closing remarks.
Thank you.
Thank you.
Thank you very much.
Thank you, Karen. And just before we hop off for the evening, I did want to just launch those poll questions very quickly, just so we can make sure we have that all in good order for the CE credits. So we'll just take another 2 or 3 minutes of your time, and then we'll be able to let you go. So here's the first poll question. Again, if you can just take a moment to review the question based on this evening's presentation and just provide us with your best answer.
So, yeah, if you think back, do you remember which? So again, it's painful stimuli that they're going to respond to. So we know it's not mild or moderate, minimal or moderate sedation, right? Because they're going to respond to even you calling out their name. And you probably remember, with general anesthesia, do they or do they not respond to painful stimulation, right? You can take someone's appendix out under GA. So what about deep sedation? Will they respond to a painful stimuli there? Perhaps they may, perhaps they may not.
We'll just give it another few seconds there, and we'll close this poll. Okay, so I'm going to terminate the poll here, and I'll share the results.
Yeah, so the answer is deep sedation.
Perfect. So we'll hop on to the next question here. And again, we'll just give everyone about 30 seconds or so just to take a moment to answer the question.
So although you may have a patient who keeps wanting to talk to you and you might want to sedate them, I suggest that you don't pick number A, okay? Oh, sorry, that is actually the answer, except. So all the following are indications of sedation, anesthesia, and dentistry, except. So
just another couple seconds here. Okay, so I'm going to end this poll here, and we'll share those results.
Perfect.
And over to the next question. We'll just get through these fairly quickly. I need to find a way to play the Jeopardy theme song during these poll questions. Haven't been able to figure it out yet. Okay, so we'll just give it another few seconds here. See, the responses are coming in. So we'll terminate this poll here, and I'll share the results.
Perfect, great.
Perfect. And just another few questions here.
So which routes of administration allow for the best ability to titrate medications? So A says oral and sub. Well, do we titrate oral medications? We talked about that. Obviously, we do not. Inhalational and IV. Do we titrate nitrous and IV medication? You probably recall from the presentation. Rectal, we don't, obviously it's not D. And subcutaneous and submucosal, I'll let you guys figure out if we do or don't. But there's two routes we discussed that are very, very good for titrating medications, and we use it in dentistry.
Okay. We'll be ending the poll in a few moments. Okay, here we go. And here are the results.
Perfect.
And second last question here for everyone.
So remember the three life-saving measures, right? For anaphylaxis, you're giving something in an intramuscular. You remember they're losing fluids, so you want to give them fluids, and they're vasodilated and hypotensive. So one of the medications on these questions causes further vasodilation and hypotension, and you definitely don't want to give them that one medication that is here, because you could probably kill them actually if you give it to them.
Okay. So I'll be ending the poll now. And here are the results.
Yeah, so you don't want to give them nitroglycerin.
Okay. And the last question for the evening here.
So we didn't talk too much about this, but you probably know this yourselves. You cannot give more than the doses of oral minimal sedation for the patient to take at home. And if you know what the maximum dose for oral minimal triazolam is, then that would be the correct answer here. Because you can't have them take anything that would take them past minimal sedation for them to take at home.
I'll just give it another few moments here. Still see some answers coming in. Okay, so I'll be ending the poll. And here are the results.
So it's 0.25. That's the maximum dose for oral minimal sedation, and you can't prescribe more than 0.25 for the patient to take at home.
Perfect. So this concludes all of our questions for this evening. Let me just check and see. I believe that's all the questions that we have. So I want to thank everyone again for joining us this evening. And just a quick reminder to register for our upcoming webinar that's on October 25th. And again, I'll just place the registration link in the chat box. I've also added the email address and the telephone number so you can contact for any other further questions. So thank you again, everyone. Enjoy the rest of your evening, and we look forward to seeing you in a couple of weeks.
Thank you. Thank you very much for the opportunity.
Thank you.
Thank you.
Thank you.